Welcome to 4 Quarter Lives, podcast exploring the profound impact of longer lives and careers on, well, everything. Countries, companies, couples, and careers. I'm Avivah Wittenberg-Cox, and on this week's 4 Quarter Lives, I'm delighted to talk with Helen Bevan, one of the most influential voices in healthcare leadership and large-scale change. Helen has spent her career helping organizations and the people within them lead change, not from the top down, but from the middle out. As Chief Transformation Officer at NHS Horizons, she has shaped how systems as complex as the NHS, the UK's National Health Service, think about leadership, agency, and collective impact. In a world of longer careers, repeated reinvention, and constant disruption, Helen's work offers powerful lessons about how individuals lead across transitions and how organizations can unlock the wisdom, energy, and courage of people at every stage of life. Welcome, Helen Bevan, to 4 Quarter Lives. I'm delighted to have you.
Avivah, it's fantastic to be here. And as somebody who, I'm in my mid-60s and I'm thinking about the rest of my life and where I go from here, I'm very inspired by you and your message and what you do. So I'm a very happy contributor.
So we'll be role modeling a little bit what a couple of 60-year-olds can still give to the world with this conversation, I think. Because in terms of inspiration, right back at you, Helen. You have spent decades working inside systems that are constantly under strain, like the NHS. How has your own relationship to change evolved over the course of your career? How do you think about it now?
It's interesting because I think there are certain aspects about change and certain principles that have been absolute consistency. And then my views and my practices are changing all the time. So I've worked as an internal change agent supporting very large systems in the National Health Service in England since 1991.
That's a long time and a lot of change in those decades.
And I think also being an internal change agent, I think is one of the hardest jobs to do because you're constantly challenging the status quo and practices that can be changed, and you're pushing the system. And yet at the same time, you have to take the system with you. So one of the ways I would describe it is rocking the boat and staying in it. In a sense, when you're a change agent in a big system, if you haven't got the legitimacy of the formal system behind you, you're not going to make much progress. And at the same time, you're challenging it constantly and, seeking to bring in new ideas and new perspectives. So this whole idea of working with legitimacy on the one hand and novelty and emergence on the other, it's a very, very tough tension. One of the things I guess I'm proudest of is, I'm still working in the NHS now as an internal change agent. And over a period of time, being able to stick at doing that, in a sense, I have rocked the boat an awful lot and I, touch wood, haven't fallen out, I think is, it's not an easy path. And I think it's probably one that a lot of people wouldn't choose. But the great thing about it, I think, is that when you're at the centre of a big system and everything lines up change-wise, as a change leader, you can make a very big difference. I like to think that I have. But going back to your question, my thinking and my practice has changed a lot over the years.
Give me a bit. It's a very powerful metaphor for our times. I think this rocking little boat that you're desperately trying to stay on and still change direction of. Give us a sense. 35 years at the NHS is quite the journey, quite the rocky ride. Give us a sense of. You say some things have changed. Some things about change have not changed. There's some stability in it, and some things have. What's the latest thing that you're now working on?
So I think the things that are pretty consistent is, if you're trying to change a big system. So, when I think about some of the initiatives that I've worked on where, we're trying to improve cancer care for people across a whole country. Okay. Or, we're trying to bring care closer to home so it's more supportive of people. Like, we have to work in systematic ways. I would talk about improvement science or implementation science, which are evidence-based ways of making change happen. So, you can't just go in and think you might do a small project somewhere and then you're going to change care across a whole country. It doesn't work like that. So I think that the absolute consistency is working in systematic and programmatic ways and using change and improvement methods. We know that if they're done well, going to make a difference.
So give us an example in cancer care.
Give you an example. So an example in cancer care, for instance, would be if you thought about a particular kind of, or a group of people who are suspected or have a particular kind of cancer. If you look, for instance, say gynecological cancer, women's cancers, what happens very often is that women will be referred from their general practitioner for specialist tests, and every woman gets referred in the same way and goes into the same queue. But we know, in terms of improvement approaches, that some women are very likely to have a lower risk or, from the symptoms, could actually go through a very standardized assessment process. And other women from their symptoms will need to be put on a different care pathway. And
so there's a predictive capacity based on symptoms that allows you to triage more.
Yeah, exactly. And put people onto different pathways. And that means that everybody will get through the system more quickly and effectively and get a more customized process.
That seems like a really simple, we know here are some symptoms that should go down this fork and here are some other symptoms that should go down that fork. Is that hard to change in the system? How long did it take
sometimes,
to change that kind of thing?
It's always changing, because in a system where you've got clinical practice that is very well established, people like to work in certain ways and teams like to work in certain ways. And when you're saying, for instance, to a doctor and oncologist, actually, we could experiment here and we could change the process. And this particular test or this aspect could be done by a really well-trained nurse under your supervision to free you up to do more complex work. Sometimes we don't manage the change process very well, so it will feel to that clinician that change is being done to them, rather than actually we go about the change in a way where people feel that change is being done with them or being done by them. So how we actually go about the change and the extent to which people feel, a sense of control and autonomy and engagement in the change is really, really important.
That leads a little directly to my next question, because a lot of people, particularly in mid-career, feel that they really need some kind of formal authority to be able to make a difference. Either they think they need a title or status. And as you said, you need credibility in the system. But your work actually really challenges that assumption. What do you wish more Q3 professionals understood about their own potential agency?
Honestly, Avivah, when I look back over my career and my change experience, number one thing I'd say is that, change doesn't really start from the top of systems very often. It starts from individuals who have got some really good ideas of doing things in a different way, and a group of people coming together, loosely connected with common purpose, making some change happen. And the kind of power and influence that comes through informal power is typically more effective for making change happen, and particularly for making big change happen, than the kind of authority that comes from having high status in a system.
How do you get people to believe that?
Well, I think, like we see it in so many effective change agents, people don't change their opinions or their beliefs based on a communication or even data. People change what they believe because of what their peers. And that's why, again, in a clinical environment, wanting to make change happen, it's so important that it's a peer-to-peer change process, because, somebody who's a doctor or a nurse will be far more influenced to change from somebody like them than because a senior leader tells them to change. So in a sense, we have to organise our change processes, working through peer groups and networks and building informal power as much as we need to work through the formal system.
You're pretty famous for the idea of change from the middle. You're describing a little bit why there's middle, and I'm curious about the middle as midlife as well as the middle of a hierarchy. Is so powerful.
I think that's a great way of putting it. I would say that by and large, people talk about like a dichotomy of change is either top down or bottom up. Actually, I think change is much more likely to be side by side, by people connecting with other people. And it's not to say that you don't need the legitimacy of the formal system, because we do. And if you look at every kind of major social movement in the world, it starts as a kind of a side by side, grow it from the middle process. But if we're going to make a really big difference, then we need to have media on board, and we need to have policymakers on board, and we need to have people with formal power on board. But typically we wouldn't start, from a place of formal power. So my advice, to people who are mid-age, mid-career, is that you have an awful lot more power to make change happen than you think you do. But very often we judge it by where we are in the formal system, and we think, I haven't reached that height where I can make decisions and I've got the power to change things. Actually, very often when we get to mid-career, we've built a whole load of relationships, really important ones, with a lot of different people. And part of what we have to do, I think, is to appreciate and work through our relationships. And, there's this old model from Stephen Covey from 1997, and I was using it a lot before, and recently, because in our system, it's a really, really hard time. There's more and more demand for health and care services, and finances are extremely tight. And so many people are saying, I don't feel I can make much difference. And I think, if we go back to this classic Stephen Covey model, which is about circles. And he talks about, a circle of control and a circle of influence and a circle of concern. And a circle of control is something that we can actually, we've got control. We don't need to get anyone else's permission to do. We actually can just do it now, things that we can actively control. And then we've got the circle of influence, which is we might not be able to control things exactly, but we can work with and influence an awful lot of other people to make change happen. And then we've got the circle of concern, which is about bigger things that are happening in the world. So again, in my NHS context, the pipeline of workforce and workforce shortages, big, geopolitical issues, government policy, we can't change that. So let's focus on the things that we can control, and particularly the things that we can influence by working side by side with other people. And I think it astonishes people often just how much power they have got. And one of the things, one of the big directions that we're seeing now, and a new source of knowledge, is an area that's growing in the field of people science called organisational network analysis or system network analysis. And in the kind of field of workforce and HR, this new research, this new science is giving leaders an awful lot of perspectives, because what organisational network analysis does enables us to understand relationships in organisations, and it helps us to understand where the power is. And the people with the power are, the people in organisations who are at the core, if you like, of the informal network. Yeah. They tend to have far more power for change.
So we'll be able to sort of heat map across an organization the nodes of individuals who have lots of connections. And influence.
And there's a Danish organisation called Innovisor. And what they've done is they've done this kind of analysis with, 100 plus different organisations across many different sectors. And what they're seeing time and time again in their analysis is that in a typical organisation, there'll be about 3% of the people in that organisation who are driving about 85% of the organisational conversations.
Wow.
And these 3%, I mean, I would call them like super connectors, like super influencers. And what happens is that formal leaders typically don't know who these informal leaders are. And again, what happens is people who are formal leaders in organizations are wanting to initiate change or undertake an organisation-wide or division-wide change initiative, but they don't get involved in a dialogue with the informal organisation. They only work through the formal organisation and cascade.
Is there any way of characterising or identifying? How do you tell who the 3% are without the AI map telling you?
Yeah, I think it's pretty easy actually. So you can do, obviously you can do the formal analysis, but when I go in and work with people in a healthcare organisation, I just go around and I ask people, when you've got an issue, who do you go and ask for advice? Or I'd say, whose opinions do you really trust? And I reckon after about 10 people, I can work out who the super connectors are. It's not that difficult. And
3% is not a lot. So
no. And again, in Avivah, their analysis is showing it's consistently around 3% in, public sector, private sector, not for profit. It might be 4% or it might be 5%. Or it might be 2%, but, there are these informal influencers everywhere. So, you said to me right at the beginning of this conversation, like, how has my change practice changed? And a really big way that my change practice has changed is working with the informal system as well as the formal system, and putting a lot of effort at the beginning, around understanding who these influencers are. And, very often, like I'll work with chief execs and they'll say, we're going to build a network of change champions for our new change initiative. And they'll get people to, either the leaders will nominate people to be the change champions or people will nominate themselves. But one of the issues with doing that is they aren't necessarily the influential people. Yep. So I would never recommend, creating a change champion network unless the change champions were at least peer nominated.
Yeah, absolutely.
Yeah.
And I'm curious if age plays anything in we're going to have much longer working lives. We're aging societies. Clients and users, patients are going to be aging dramatically in the UK. I'm curious if age overlaps at all with these super connectors. Is the longer you are in a system contributing to some of the identification of these people?
That's exactly right, I would say, Avivah, that, obviously it's relationally based. So, people that have been in the system for a while and are credible with other people in that system often have more informal influence. There's a flip side to this as well, which is about people who are cynical and even skeptical. And very often, even influential people that have been in the system for a while, like, people don't start off skeptical or cynical, particularly not in a healthcare environment. Somebody who chooses to dedicate their life, to a health and care mission are not typically cynical people. But what happens very often to people is people come up with ideas and they don't get a voice and their ideas get pushed aside. So people end up giving up. So, I think there's some dangers of that, as we age as well.
Because healthcare strikes me as a sector where very particularly age, expertise, and emotional labor intersect a lot. So what have you seen? What does the NHS teach us about valuing and reigniting perhaps these really seasoned professionals who've given up? Or do you not work on them? Do you still?
I do, because very often older colleagues are the most respected, influential people, and actually working with those colleagues first can be a really, really great strategy. So, very often, we think, let's go and work with the younger generation that have got loads of new ideas, and we like that as well. But, if we want to really understand the organisation and we actually, want to make a difference in the organisation, then we might want to start in a different place. And so much of this is relational. So I would make a distinction between somebody that's sceptical and somebody that's cynical. And, very often people who are sceptical can make a massive contribution to change. But it's part of the reason why, when we're doing these kind of change initiatives, we should always follow up. Can I tell you a story about this?
Yeah, absolutely.
Okay. So I used to help lead the Cancer Improvement Programme for England, which was called the Cancer Services Collaborative. And we had an evaluation of this programme. And we brought in some qualitative researchers. And what we asked the researchers to do was, because we had a whole series of cancer doctors who used to be skeptical about quality improvement, but had now become champions of quality improvement. We asked the researchers to find out what were the factors that turned somebody, a doctor, from being a skeptic about quality improvement to being a champion.
Yep.
So the researchers did the study and none of it was kind of rocket science, but it was useful. What they also found, which was actually more interesting, was a subpopulation. And this subpopulation was doctors who had started off being skeptics about improvement, had got involved in the Cancer Services Collaborative and the improvement work, and their expectations were raised and they thought some really great things were going to happen, but it wasn't followed up. So they became skeptics again. And what the researchers found was the skeptics who became champions but then became skeptics again were far more skeptical than the people that were just skeptics in the first place.
Disappointed hopes, yes. I can imagine that.
And I think there's some real learning in this, which is, we've got an awful lot of older, experienced colleagues who, have got huge wisdom, are very credible to other colleagues, but they're skeptical. And these are some of the people who can make the biggest contribution to change. So, they have the crystallized wisdom that comes from years and years of experience. They've got these strong relationships. And we need these colleagues to be at the heart of our change process, because we know, and the evidence tells us, they can be some of the best contributors. So whatever else we do is, if we start down this relational road and seek to involve these colleagues who, have been skeptical up until now because they haven't necessarily had great experiences, we must follow up. And there's a Dutch saying, which is, trust comes in like a tortoise and goes out like a horse. And again, I think it really fits in, with this idea about people who, have worked in a system for a long time. Okay, it takes a very long time for people to build the kind of trusting relationships that we need for great change initiatives. And if we don't work in an effective way and we promise we do something and we won't follow up, we can lose it so quickly.
So I'm curious, in a system that's obviously under strain, is going to be more under strain, and we've got these skeptics who've tried to be champions and become skeptics. How do you help them keep hope, courage, energy when they're, especially those who are leading without formal power, who must feel like they don't control, they don't have the responsibility, and they just can't. And sometimes this is not a question of months, but years or more of effort. It's a very tough context. What have you seen? Does it work? Is there a way through? What have you seen?
Probably my number 2 conclusion would be, you can't be an effective change agent on your own. And I've seen it with so many, young clinical entrepreneurs coming into the system with loads of great ideas, and people end up crushed, or they can do, because however great your ideas are, however passionate you are, however great your values are, you're working as part of a system. Like when you're in a formal system, whether it's a business or it's a healthcare organisation, the formal system is designed, to keep things controlled, to minimise risk and sustain the status quo. And as a single individual trying to fight the system, it's almost impossible. So, we have to find other people to connect with who want the same things that we want, and work on change together. That's why, communities of practice, communities of action, peer groups are, so important. And many of us are lucky, and I've been lucky in my career because I've had some fantastic line managers who've kind of recognised my contribution and have given me air cover, given me loads of opportunities. But I haven't always had that. And very often, we're in situations that can feel incredibly lonely. So we have to find the connections for ourselves, and we have to help other people to make connections. And when we start, working in projects of change, like with those cancer doctors, if I'm the leader of a change program, I have to work in very honourable, respectful ways and always follow up what I say I'll do.
Helen, you've worked on these themes of change and innovation and redirection in countries all around the globe. Are there some cultures or countries that you have seen are particularly skilled at change? And if yes, what is it about them that makes them maybe easier places? And where is the UK situated in that?
Yeah, I think there are definitely places and localities that are better doing this. So like one place that really inspires me is Jönköping in Sweden, which is one of 21 Swedish regions. And if you look at like any indicator, how well Jönköping manages its money compared to other health systems, how people of all different ages, they trust the system, how accessible the system is, how clinical qualities. Jönköping is at the top, of the league table of Swedish regions. And it's deliberate because, 20 years ago, the leaders of that system invested in deliberate ways of working. So they, work with quality improvement. They made a decision to work in very patient-centered, people-centered ways. So they have a question, and it's about a lady called Esther. And Esther is a woman in her 80s who's got complex care needs. So whenever they're making a decision about patients or changing the system, they ask the question like what does Esther need? And, they've gone about their leadership development in a way that trains leaders not just to be great individual leaders, but to work as kind of collective leaders, so that care, it isn't just about what this department does or what that department does, but that leaders work together like really, really effectively across systems. And again, Jönköping hasn't got any more money than other Swedish regions. It's just got different habits and practices and a more systematic way of working. And places like Jönköping really give me hope. So how do I think we're doing? Well, I know the NHS, very, very well. And I think that it's very easy to be critical of the NHS. And I think that, unfortunately, not everybody gets a great experience of the NHS, and it lets people down. And when I compare it to other health systems, even with some of the challenges that the NHS has got at the moment, I'm really happy that I'm in England with the NHS and not in other countries, particularly some countries. And how I feel about it is, people say to me, how can you get to 37 years in the NHS and be so positive and hopeful and energized about it? And I love what the NHS stands for. And the people in the NHS are just amazing. And ever since the NHS was first set up in 1948, it keeps changing all the time. And there's been times when performance has been better and performance has been more challenging. There's times when more money has been available because of what's happening in our economy and less money. But the people in the NHS are really adaptable. And I think that, I just kind of feel hopeful of the people, and I really kind of respect, the kind of older generation like me and the contribution that we make. And I have a lot of hope for the new generation that are on their way.
I think that's an inspiring tone for a new year, a strong belief in an old existing system that's under strain, but values based with lots of terrific human talents waiting to be. So I'm maybe just to close, if you were advising organizations designing work today for this new 100-year life, more preventive, less curing the sick kind of option, what's the single biggest mindset shift you would think they need to make about leadership, health, and age?
I'd say biggest shift is about really believing in people and the power of people. You know, when I look at all the hundreds of change initiatives that I've been involved in, the places that create the conditions, the people conditions, the belief in people, the psychological safety that enables people to shine, I think make the biggest difference. And I think that's particularly the case with older and more experienced colleagues. You know, like we've got such a big contribution to make, and you know, even more so into the future. We may need to work in different ways with a different focus. And again, I love my NHS role now because I'm a strategic advisor. I'm not doing the hardcore change management anymore. I work with a whole range of leaders who are, you know, like the NHS has to change so much. It has to stay the same in terms of the themes and the values, but it has to really, really change. And actually having, you know, people like me loving what we're doing in terms of, you know, helping to create the next generation of thinking and practice. And I think we could do that on so much of a bigger scale.
Helen Bevan, I think anybody listening can certainly pick up your million miles from anything either skeptical or cynical, and this kind of very inspiring hope and clear vision in what's needed, and embracing the change, not fighting it, and in fact leading it within one of the organizations that's going to role model it for many of us is very inspiring. I want to thank you for your time today, but also for all the work you've done in the last 37 years, but perhaps more importantly, in the next decade.
Yeah, and much more to come.
Much more to come. Happy 2026. Thanks for being with us.
Yeah, thank you, Avivah.
Helen, thank you for such a thoughtful and grounding conversation. What really stands out from this discussion for me is the idea that leadership isn't a phase we pass through or a title we grow out of. It's a capability that deepens with experience, perspective, and time. In a world of longer lives and careers, Helen's work reminds us that the middle years aren't a holding pattern and later years aren't a winding down, but they can be some of the most powerful moments for collective impact. For more thinking about the impact of our 4-quarter lives, you can read my column at Forbes and subscribe to my Elderberries newsletter on Substack. Let's design lives that aren't just longer, but better.